Okay, Gabby. Well, you'll have 60 minutes, and then we're going to use the remaining time, which is about 15, depending on when you end, for Q&A at the end. So let me see that you're available to share.
Yeah, that I think I still need.
There we go. You are now co-host.
Wonderful. Terrific.
Okay.
Thank you so much, Dan and Itamar, for hosting me today. And it's good to see you all. Maybe we'll have a more intimate group, and there'll be more time to answer questions. So I will get started. Let me share my screen first and see if this works. Can folks see the first slide? Yeah. Okay, great. All right. So yes, as Dan shared, I am zooming in from the Bay Area. I am a research fellow at UCSF and have been involved in various studies or academic studies with psilocybin over the last now like 11 years or so. And I'm excited to talk about some of the research I was involved with in my early my early days with the studies, and which I've been lucky enough to be able to continue to kind of weave into my graduate studies and then into my postdoc studies. So the title of my talk is kind of long, but I'll share it's From Terror to Transcendence, Processes of Meaning Making in Psilocybin-Assisted Therapy for Cancer-Related Distress. And just quickly, I'm going to disclose there's a typo already. I see it should say NIDA, not NIDH, but these are some of my funding sources, including current fellowship that I am a part of at UCSF, and then various private funding for this research. Okay, so I am going to spend the bulk of my talk on reviewing the study, one of these landmark studies that we co-published with our team or with our collaborators at Johns Hopkins in 2016. I was at NYU at the time, and we published data from a phase 2 study of psilocybin for cancer-related distress. I'm going to be talking about that study and then a couple of secondary papers that we published more recently. And then I'll be able to present some of the qualitative research that I'm really kind of most excited about, where you get in sort of rich firsthand accounts. And also we'll talk about some of my more recent research on psychological mechanisms. So, I should mention, I don't know if we mentioned that we're going to be holding questions for the end. So if you have questions, drop them in the chat. And I can come back to a slide if we need to in the Q&A portion, but appreciate if you could hold the questions for just at the end time. All right, so I'm going to be now, there we go. Okay, so cancer prevalence, I'll start off just by stating what the statement of the problem. So cancer diagnosis is affecting more and more people, globally and in the United States, and it's one of the leading causes of death. And in 2020, it actually the number rose up to 10 million deaths, and more than half of Americans report that they have a family member diagnosed with cancer at some point, and not too far off, in about a few decades from now, basically half of us, or 1 in 3 women, are going to be affected personally by cancer. So cancer, especially as we have baby boomers aging, it's just affecting us in a very prominent way. And so now I'm going to talk about the existential distress that can be associated, or that could be provoked by a cancer diagnosis. And that's been kind of the focus psychiatrically of the studies, or the primary clinical indication of the studies that we've used psilocybin for at NYU. But unfortunately, while we all of us are affected by death, we will all die at some point. In at least Western society, death is really a taboo taboo subject, and also in medical, in the medical system. We're very good. Medicine has advanced, technology has advanced so much that we actually are very good at keeping people alive, but we have done very little, or we've kind of progressed very little, or even like regressed actually when it comes to integrating death and dying into professional medical care. And the existential sort of concerns are often overlooked. And it's, as you see here on the slide, the most avoided conversation in medicine. It's, really, we're very kind of just inept at this with these kind of issues. And the treatments that we have are, we're just really, we don't have many treatments actually to address this. This disorder or this distress. And I have a quote here. I'm going to be presenting more qualitative research towards the end, but this is from one of our cancer study participants, who just kind of describes just this experience of getting a diagnosis, then death becoming so sort of prominent in her consciousness. So, I don't know that you realize that until you're told that you're going to die. I was told I had a 50-50 chance of being alive in 5 years. As soon as you think about having time or limited time left for living, it changes everything. And I'll also just add, actually, before I go to this slide, just how kind of cancer in a cognitive way, and I'm going to be talking about, as a psychologist, I'm very interested in the psychological dimensions of this syndrome. And really what, cancer kind of does, it does when it strikes the belief systems and like the schemas, the cognitive schemas, the sort of narratives that we hold about ourselves that provide sort of a sense of stability and familiarity, that can get shattered when you have a cancer diagnosis, and it can provoke this search for meaning or this existential plight as a sort of way of trying to accommodate and assimilate the cancer diagnosis into one's sort of sense of identity. But many people struggle with that. So the people in our study were the people who really struggled to kind of adjust to the diagnosis. And as I just mentioned earlier, we really do not have many treatments. Psychotropic medications, SSRIs are often used. They are not there's not a high evidence base to support the efficacy of medications to treat existential distress associated with cancer. And this also, is not in the DSM. We don't have an existential sort of distress disorder in the DSM. And it's really kind of can we think of it as an existential and also spiritual distress. People's value systems get disrupted. And so there's really not much that we have to target this more spiritual dimension. And we also have some psychosocial treatments like group-based therapy, meaning-focused therapy, but there's not a whole lot of good evidence either for those. So now this brings us to psilocybin therapy and how might psilocybin improve these effect sizes, these outcomes. All right, so I was thinking maybe I would take a poll just to see how many people are familiar with psilocybin. I will do a quick review. I'm sure most people know a little bit about, what psychedelics are, but I will just do a quick review. So psychedelics, even though they're pretty new to our Western armamentarium, or at least in our sort of tools using or for interventions in the medical sort of system, they're new. There is a very long history of ritualistic use, mostly in Mesoamerica and down in Mexico, but psilocybin mushrooms are found in almost all continents, I think all but one. And at least 9 indigenous groups in Mexico have used psilocybin mushrooms as a sacrament. And I just really want to point out that we draw a lot of knowledge and wisdom from these ritualistic indigenous uses, and the frameworks that we use, even though they're more, they are westernized, we do owe a lot to to these to the more sort of group-based, community-focused spiritual ceremonies. There we go. Okay, so as you can see here, psilocybin is a close cousin to other other molecules like serotonergic based molecules that you might be familiar with, like serotonin. Actually, serotonin and LSD were discovered around the same time, as was psilocybin. Psilocybin belongs to this group of serotonergic tryptamines, and serotonin is a primary agonist at the sub-receptor of the serotonin system, the 2A receptor. So that's like that's the key receptor to, you know, if you're thinking about psilocybin or LSD, that is the key to the subjective effects, and produces kind of this profound, intense altered state of consciousness that involves shifts in cognition, emotion, perception. And this experience lasts about 4 to 6 hours. And yeah, I'll talk a little bit more about what it looks like a study session in a few slides. So I put the slide up here just because I want to just, you know, now I think we are less politically, our beliefs about psychedelics are less politically driven and more scientifically, you know, grounded. But, you know, there has been a long sort of, you know, long history of people not really understanding the physiological or relative sort of harm potential of serotonergic psychedelics. And so Peter Hendricks is actually an author on one of these papers that really describes the relative sort of safety of psilocybin. You can see here on the left, the graph, alcohol has been rated to be one of the most harmful of all substances, recreational substances that you can find. Mushrooms on the far end in terms of you know, potential for harm to, you know, individuals and to society. Okay, so, you know, building up this kind of rationale for why psilocybin or psilocybin-assisted therapy might be a helpful intervention to address the spiritual existential distress. So, you know, I'm going to talk a little bit now about how there were several studies in the 60s and 70s before the Controlled Substance Act prohibited or put a moratorium on most of the research. Some research continued, but at least you know, psilocybin and LSD were rescheduled into this most restrictive category. So the research that took place before that happened there was a rich body of it, and there were over, I believe, around 40 to 50,000 participants who were research participants in clinical trials with mostly LSD, but there were you know, some with psilocybin, and looking at you know, psilocybin or LSD there are other substances like DPT as well, but they were studied pretty widely, and there is, you know, a pretty nice signal for the you know, preliminary efficacy to alleviate existential distress. Also, alcoholism was the other most studied indication. And what the kind of formulation for why this might be helpful was that these substances could facilitate this peak or quantum sort of change, transformational experience, leading to kind of spiritual insights and then behavior change. And so this is a famous study on the right, the Good Friday experiment, that kind of paved the way for a lot of the contemporary research that we draw so much of our, you know, more recent kind of scientific insights from. And the Good Friday experiment, this you maybe have, for folks who attended some earlier talks, it's possible that you've heard this, so I won't talk too much about this, but 1962, I think he was a professor at the time, or maybe he was still a student, but Walter Pahnke, who was, he was at Harvard, and he enrolled 20 participants in a study that administered psilocybin and a placebo niacin to divinity students on the Good Friday holiday. And half the participants who had the psilocybin basically reported that their experience was as, mystical as they would have experienced in, another setting in a sort of religious, spiritual context. And on the left, Roland Griffiths, who's one of the leading researchers in this field, he kind of replicated that study. And you can see here, this is sort of healthy volunteers, that people are rating an experience with psilocybin compared to the placebo, which in his study was methylphenidate. But people are reporting these experiences are, mystical in the top 5 personally most meaningful or spiritually significant of their lives. So there's something about these experiences, it gives us a clue for why these might be helpful in kind of alleviating the existential distress that cancer participants experience. Let's see if there's anything else I want to say about that. No, I'll move on to ego dissolution. We can't talk about psychedelic therapy or psilocybin therapy without talking about ego dissolution, which, ego is not a bad word. Ego is really just refers to like our sense of self, our sense of identity, the sense of self that we really need to rely on to navigate the world in our daily lives. But it, this sense of self, or this sense of like I, it's like distinct from this world, from the world, and this sort of boundaried sense of self. This usually gets sort of this experience shifts, and usually what happens is we call ego dissolution is this sort of diminishing of boundaries or sense of a boundary between self and other. And when that happens, we also see that this region of the brain that is being more studied in the past 2 decades, it's all over the place. The DFOMO network, where you can see in many different papers, which refers to this sort of region of this network. So it's not just one region, but it kind of covers many regions, and it's the sense of self, or even this part of the brain actually gets activated when your mind's wandering. It's this sort of part of the brain that usually is also associated with rumination, and is highly hyperactive in across many different kind of emotion-focused disorders that are characterized by rigidity, rumination, kind of perseveration. And so one of the leading scientific theories, or informed by some neuroimaging, is that when we have ego dissolution and this kind of this shift in brain patterns within the DFOMO network, that this sort of flexible state of consciousness gets activated in people who have more rigid sort of ways of perceiving themselves, perceiving the world. This could be very helpful. That's sort of creates this window in which new learning can take place. And also, this theory also proposes that information from the limbic system, so this sort of emotional information that is otherwise constrained by these executive functioning or executive processes. I'm sorry, there's a blower next door. Is that hopefully not too loud, but let me know if it's interfering. But so we get this kind of relaxed cognition and more information flow coming up from the limbic system. People describe greater access to emotions, and then we get this kind of like reset of the brain. So this sense of self that gets tightly wound gets kind of relaxed. And I'll talk more about that in a little bit. And then this colorful slide that maybe some of you, or this colorful image here with placebo and psilocybin. Oh, I'm sorry, there's actually, it looks like part of my images actually, something's happening over here. But the placebo psilocybin slide, or this image here, is showing these homological scaffolds. Really, it's just showing that there's more communication taking place in the brain with psilocybin. So areas that otherwise are just kind of siloed, you see this kind of healthy new kind of web and networks being formed between parts of the brain. So just more communication between other parts of the brain. And let's see, and I'll just say that this is different, that the sort of primary mechanism that we sort of are beginning to, see that psilocybin is recruiting here is very much different than SSRIs. So what people often describe with psilocybin is this kind of intense affect. SSRIs tend to sort of diminish the window in which one can experience like a range of affects. I'm so sorry about the background noise, but hopefully it will. Is it really bad? Can you still hear me? Okay, great. So with SSRIs, this kind of window of, or this range gets diminished, which can be very helpful for people who are really, feeling too much in sort of intensity of their emotions and need some relief. But with psilocybin, we have a different sort of mechanism here, which is greater access to emotions and less constrained cognition. So I'll come back a little bit to this. I know that was a little bit of just a lot of information there, hopefully not too much that to digest. I want to talk now about the studies of design that of a study that took place at NYU. We co-published with our collaborators at Hopkins. This was a phase 2 double-blind randomized controlled trial that involved a crossover design, and we had psilocybin administered to everyone, but half the participants received psilocybin first, and the niacin second, and the other half received the placebo niacin first, the psilocybin second, with a crossover at 7 weeks. So whichever condition they were in, they crossed over, and we had 29 participants in that study. So here you can see a diagram of the sort of the timeline and the schedule of sessions. So there were 3, we had a lot of therapy we had a lot of therapy in this study. So there were 3 therapy sessions before their first medication session. And then there were 3 in between the first and second medication session, with 3 following. So there were 9 therapy sessions, and then we had a lot of follow-up check-ins. But yes, we were not just giving psilocybin without any other, it was really embedded within a therapy heavy sort of design. And as I mentioned, psilocybin, the 2 conditions, either psilocybin first or placebo first, with the other one after the crossover. And we administered, our primary outcomes were depression and anxiety with HADS and the BDI, so the Hospital Anxiety Depression Score and the Beck Depression Inventory. And we had these other secondary set of measures looking at existential distress, spirituality, and quality of life. And then we had some follow-up periods. I'll talk about that in the next few slides. So there's a lot of text on this slide, but this just describes the platform we used for those 9 therapy sessions. We drew on existential, sort of existential paradigm here, with supportive psychotherapy really focusing on meaning making and preparing people to have like a highly spiritual experience. And we took the history of their cancer story, their history of their life, sources of meaning, wanting to understand kind of how they've coped. And then during the medication session, we encourage them to try to really kind of stay open to whatever emerges. And for many people, this could be, difficult and scary content for a lot of people, especially in the beginning phase, like the first 45 to 60 minutes of the session could be during that sort of peak of like the ego dissolution phase. It can be really destabilizing and really scary. So this mantra, trust, let go, be open, to surrender to whatever comes up, reminding them that they're safe, that the drug will wear off at some point, is really important in the preparation. And then integration, as it sounds, integrating what comes up, processing, the insights and the material arising from the experience. I think I also forgot to mention the dosage. So the dosage we used was 0.3 milligrams per kilogram, which roughly came out to be like 25 to 30 milligrams of psilocybin. This was a synthetic psilocybin. And people always ask, what is that equivalent to in dried mushroom? And we usually say it's about 3.5, 3.5 grams of dried mushroom. But very hard to kind of compare because there's so much else, so many other alkaloids in the dried mushroom, and we were just giving them pure psilocybin. So here's a picture. This is not, these are actually different. This is like a kind of simulated picture, but this is our study room. This is what the study session looks like. It, of course, looks very different than what like a shamanic ritual would look like, although we do bring some kind of elements into the session. But there are 2 therapists, and the participants encouraged to lie down on the bed or couch, and we have a pre-recorded music playlist. Not much talking is happening, actually. Most of the talking happens in the integration sessions or the sessions afterward. Although we do have brief check-ins and blood pressure is measured. And also with psilocybin, it's sometimes, especially with higher doses, it's usually not a talkative medicine like MDMA. I think Rick, who presented here last time, yeah, if he shared any of the, some of the findings from the MDMA studies, that is a very different kind of model, and the mechanisms are different. With MDMA, there's more kind of relational therapy that can take place, but with psilocybin, it's much more inward. All right, so our findings, here are the findings up until that crossover point, up until the 7 weeks. This is our kind of true between group comparison between the folks that got psilocybin first, and then so between the folks who got psilocybin first and the participants who got the placebo niacin. So you can see here we have very large effect sizes. Someone actually asked me in a recent talk I gave, like, what is the comparators to like the evidence-based SSRIs? SSRIs, I believe, are somewhere in the range of like 0.3, maybe even lower than that, to like 0.5. So we're getting here like more than twice the effect here, compared to placebo. But it's also interesting to see that placebo group are also improving at that green line. That demarcates the drug administration. This is the first drug administration point. Everyone's getting better. But you can see that it's much more pronounced in the purple group, which is the psilocybin one. And then you can see with like the, it does come up a little bit. It actually seems to kind of like stabilize for the placebo group, that they maybe are getting better. Clearly there's a, we call set and setting effect. So the therapy, all the preparation, the mindset of the participant going into the experience, as well as the sort of environment that's created around this, there's clearly has an effect. But what we see here is that psilocybin is much more strongly influencing the outcomes. And then we also found that the strength of the mystical type experience measured by this assessment called the MEQ, which was developed at Johns Hopkins by Dr. Griffiths. We used the scale in our study, found that it mediated, which so basically means that the relationship between the condition and or psilocybin versus the placebo and reductions in anxiety, depression were explained or transmitted through the through the mystical type experience. And this is only up until 6 weeks, though, or maybe to the 7-week mark. Or sorry, I think it's 6 weeks. And I'll talk a little bit more about what other mechanisms might be at play here. And we did a follow-up study here, same or mostly the same group of participants that was in the primary study. And we did a sub-analysis looking at the effects of psilocybin on suicidality and loss of meaning. And what we found was that you can see here again the psilocybin group and then the niacin group both improving. We didn't find a between group effect with well, we didn't find data between group PSF with psilocybin and niacin between those two groups, but we did find significant within group reductions for the psilocybin group. So it seems to be probably a power issue, but it does seem like if we had a larger group that there might be an effect here between group effects with psilocybin. Leading to reduced suicidality, but we did see loss of meaning, which is a related construct and is predictive of suicidal ideation. There was an effect between the groups and within the groups as well. So that is pretty interesting. And we also found a correlation between reductions in suicidality or suicidal ideation and depression. It's pretty high correlation, but small again, it's very small sample size. So that's interesting. And actually Dan co-authored with Peter a review on psilocybin for suicide, or maybe it was psychedelics generally for suicidality. So this is a newer area. It's very exciting to think that psilocybin might be a useful useful in our toolbox for this, in addition to medicines like ketamine, which has it's becoming widely used for depression and suicidality. And now I'm going to talk about a study that I conducted, another secondary analysis that we did with the cancer data. This was a pretty small sample, only 15 participants who were actually still alive at this long-term time point, but we wanted to re-administer the primary assessments to see if the reductions that they had reported were persisting at these many years later. So we re-administered the primary outcomes, depression, anxiety outcomes, and some secondary ones, including hopelessness, demoralization, and quality of life. And we found, so this is not a very, it's not the most rigorous analysis because we don't have a control group at this far out time point. So everyone here has received both the psilocybin and the niacin, and they're collapsed at this stage, these groups. But so we did this within group analysis, looking at just longitudinal changes. And pretty exciting because here we see that all these years later, basically 3.5 and 4.5 years later, these reductions are continuing to persist. And we did look to see if it was related to cancer stage or remission status, and it wasn't. So that is really interesting. Granted, there were people who had passed away prior to this analysis that we couldn't include, that may also be, would have maybe impacted the data, but it is an interesting preliminary suggestion that it could be persisting all these years later. And response and remission rates also persisted all these years later. These are the HADS is the Hospital Anxiety Depression Scale. So we looked at anxiety, depression, and then BDI, the Beck Depression Inventory for depression. And so the response rate is defined as 50% or greater reduction from baseline to this long-term follow-up point at 4.5 years later. And there were something like 60 to 80% of participants were still reporting clinical response. And then with remission for depression, you have to have the 50% or greater and a score below 7 or 12 on the HADS or the BDI. And for the HADS, at least 80% at 4.5 years later is still reporting clinical remission. So that's also interesting. And then I think this might be the last slide for this study, showing here that it looks like as time is going, as time passes, there's a relationship between the passage of time and the reductions in depression and hopelessness. So it's, potentially that is continuing, they're continuing to get better as time goes on, or they're continuing to report reductions. And these persisting effects also, we're also seeing persisted at this time point. And I did look to see if the mystical type experience, so like the strength of a sort of spiritual type experience was predictive of these effects, and it wasn't. It could be a power issue, but this kind of set me off on a on a path to look at other psychological mechanisms, which I'll talk about next, that might be driving longer term effects. So as I mentioned, I've been involved in the qualitative research, or a lot of qualitative research, which has been really, really meaningful and rich, experience for me to gather kind of firsthand accounts of participants in these studies. So here I have some of the studies that I've been involved with, and I, starting to sort of see here, even though psilocybin hasn't been used to primarily target trauma. MDMA has been mostly used for PTSD treatment, with this one study that also looked at existential distress. This was in a long-term AIDS survivors group. We are seeing, and also in the cancer participants, we're seeing these reports of post-traumatic growth and sort of this like recontextualization of past traumas. And so I'm going to highlight some quotes from these studies that give us a little bit of clues to maybe about what's, how cognitively and emotionally that people are using the psilocybin experience to kind of heal from painful memories from the past. So here, I won't read all of these quotes, but I will read the second two. So this child that survived all of that is really strong. The person I was then, that endured, who became what I am today. If I can take some strength from that child, bring it into the adult, that it's become like, I think that's a useful thing. And this is another person from the cancer study. Some of this trauma is my defining narrative, but it's at the same time, it's this way of keeping it as a part of me without defining me completely. So yeah, kind of after psilocybin, being able to sort of expand their sense of self and identity that's sort of bigger than their traumas or bigger than their painful pasts. And then also, psilocybin and other psychedelics can really help people heal relational wounds. One of the hallmarks of the mystical type experiences is this sense of interconnectedness, unity. So a lot of people reporting this sort of this mystical type experience in which they're feeling this sense of connection with loved ones or with the universe, as far into the cosmos. But a lot of people learning to forgive or coming to a place of forgiveness with loved ones that they had harbored resentment towards. So here, I'll read the second one. I let go of a lot of anger and resentment towards my parents. I thought I'd done that already, but I really hadn't. I saw them more as these flawed human beings who did the best they could. And then this more spiritual, transpersonal insights around feeling part of the collective minds, realizing, oh, this exists, we're all just facets of this, and connecting to a wider sense of life or consciousness. So again, this kind of these insights and around reinterpreting, kind of uncoupling from these sort of identities that were rigidly kind of bound to to these historical events, and then forgiving people, reinterpreting, reappraising, and I'm going to talk about flexibility and reappraisal now as possible mechanisms that I've been studying. So let's see, how are we doing on time? Okay, I'm doing well. So I am highlighting here a couple of studies, a recent study that was just published looking at psychological flexibility and reappraisal, and the study by a colleague, Alan Davis, that found that psychological flexibility is mediating the acute effects of psychedelics or psilocybin on either reductions in depression and anxiety or improvements in mood. And returning to this idea from that slide that I showed you earlier with the brain and this relaxed, returning to this idea of relaxed beliefs, increased access to emotional content, And it's, we're beginning to see that possibly that this sort of acute flexible state paves the way for new learning, new habits, and then these increases in this sort of flexible kind of attitude towards one's sort of self and in life seems to be meeting outcomes. And I also, beginning to develop this, I'll show on the next slide, scale that I'm developing with acute reappraisal as an acute, as an acute phenomenon that might be taking place during the psilocybin or psychedelic session. So, so the study that I showed on the previous slide, we use this scale that's not yet validated, but as you can see here, some of the items in the scale, this is again taking place during, this is what we're asking people afterward, right after their session, to report as phenomena that occurred during the psychedelic session. So here are some items: able to see new positive meaning in past traumas, feeling forgiveness, and realizing, able to live courageously. So this kind of reinterpretation of one's identity in life. And I have here a diagram that's just a mindfulness kind of informed diagram of what reappraisal does, is the sort of broadening of the kind of attentional space or attentional field to encompass kind of a more broad and more to be able to integrate kind of this one's attention on a negative and positive aspects of their consciousness can happen with this. It can happen with mindfulness and meditation, but it can also happen with psychedelics. It seems that this this highly flexible, broadened state, and then you can see people are less focused on the negative and able to kind of integrate positive and negative. So this is kind of my working hypothesis about what might be happening. And this hasn't been tested, so this is not yet like a validated hypothesis, or theory. But this idea of this ego dissolution, attentional broadening that allows for kind of new appraisals of how such events in their past that maybe they were kind of psychologically hooked with, allows for this kind of new appraisals of meaning, leading to kind of post-traumatic growth, less avoidance of emotions that are painful, disidentifying from previous thought patterns. And then in the long term, especially kind of in the context of a cancer patient who has this strong existential distress, can really help to kind of create an identity that feels more whole, less distress, more meaning, more purpose. And this is often described in a kind of spiritual context as well. So again, cancer, how this might show up within the cancer, within the cancer population that has a lot of that just has a lot of fear of death. It gets very sort of perseverated focus on on death and dying, on their cancer recurring. For participants in our study, some of them said during their psilocybin session that cancer was nowhere in evidence. If anything, it was a part of this same smoky, shadowy chaos of anger and fear. And this other participant who's had this vision of a dinner table, cancer was at the dinner table, but it was supposed to be there. And the feeling I had was cancer is part of everything. It's not this bad, separate thing. It's part of everything, and that everything is part of everything. And so this sort of acceptance of cancer. And for many people describing cancer, it was formerly cancer as like a kind of provoking of a crisis of meaning, actually, in the end, through their kind of work in the psilocybin study and the therapy, being able to describe cancer as actually almost a provoking or a trigger for this sort of new lease on life and kind of growthful sense of identity. So instead of coming in with cancer has kind of ruined my life, people saying cancer, I won't know where I'd be without having cancer. So it's very, very interesting, this kind of reappraisal of what the cancer, how the cancer is affecting them emotionally, psychologically, spiritually. So I'm finishing a little earlier than I thought, but that means there'll be some more times for questions. So limitations and future directions. Let's see. So we definitely need more trials, rigorous phase 3 trials. We are moving into that phase with the depression studies that are taking place for major depressive disorder, as well as the cancer studies. Probably I don't want to predict when, but we have some protocols already developed and searching for funding. NIH has, is now funding, the first therapeutic trial with psilocybin, led by our colleagues Matt Johnson at Hopkins. Actually, I don't know, maybe Peter is a site, it's a multi-site study, but it's finally, we've been just for decades, just sort of surviving off of philanthropic donations, and really these studies are very expensive. So hopefully NIH will continue to start to fund these larger trials, and we can understand mechanisms that govern these reductions and symptoms. And this is really crucial to developing effective strategies for therapeutic strategies. And we've done very poorly, unfortunately, at including more diverse study samples. Maybe I think Peter's study might actually be the exception to that, but his psilocybin for cocaine addiction study. But most of the sites have about 80% white identified individuals, and that's not good enough, not generalizable, and not fair, I think, to people who have historical traumas and deserve to have access to these treatments, even at the sort of experimental phase. So there are lots of efforts, thankfully, that to develop strategies for community-based participatory research, sort of community-based partnerships to help engage people in these studies. And there is a lot of mistrust, among populations that have historically been abused or mistreated in research. So that is definitely an area. And then, it's talked about a lot, but supporting reciprocity efforts, I think, is really important. And so much of the so many of the insights that people have around, within their psilocybin sessions or after their psilocybin sessions about this, the importance of connection and community and pro-social motivations. And so I hope, we hope that this will translate to more action and to support the people who are kind of the wisdom keepers, original wisdom keepers of this, these medicines and this tradition. So I just put a website here that is doing a lot to support these efforts. I have some quotes here speaking to the existential piece around, just being able to kind of overcome and find freedom in this kind of inevitable existential sort of challenges that we all face. And I think that might be the end. This is some of our study team. I'm no longer part of the primary team. I'm still collaborating with them, but there's a whole new team now. And so these pictures were taken in 2010, I believe. So they're a little dated, but now we have time for a lot of questions. Here's how you can contact me. I'm at UCSF currently, but would love to hear from folks. If you have, please stay in touch. So I can keep up my slides in case there are some questions. Maybe I'll bring it to this. Sometimes people have questions about the study design slide. So I welcome questions. Thank you so much.
Thanks so
Gabby,
much, Gabby. Oh, Peter,
sorry.
go ahead.
Hi, Peter.
Here.
Hey, yeah, I'm here. My kids are being quiet at the moment. I happen to be home with them, so I want to jump in there. That's why I so rudely inserted myself. So I apologize.
Yeah, it's okay.
But first of all, thank you so much for presenting. What a coup for us to have you here, given your experience and your publication record. So thank you so much.
Thank you, Peter.
And then, one question I have, and I should say too, I am a clinical psychologist like you. So I'm really interested in the subjective reports. I mean, that's really the most interesting thing often about the experiences people have, that they tend to be frequently so profoundly meaningful and vivid. But one thing I'm curious about, and I realize that in some ways this undercuts my own importance in this process, but I think it has been recognized by some that not everybody has an especially meaningful or memorable experience that they would say was especially that they could say much about, that they have much to report. And in fact, they may not report much of anything on the mystical experience measures, that they may not even have much to offer in a qualitative study. And yet we still see with some of these people an improvement, sometimes a substantial improvement. And I think some of the associations that you reported, that I guess we could say non-associations between subjective experience and outcome, would suggest that perhaps the subjective experience isn't crucial, at least not for everybody. So I'm just curious what you think. Like, could it be like a nod to our colleagues who are purely neurobiological in orientation, that there's just something happening, like maybe a reduction in inflammation or some sort of normalization of the default mode network, and that this subjective experience is just kind of an interesting correlate, but not especially important. And I'm saying this as devil's advocate because obviously I would like to argue that people like you and I have an important role to play, but I'm curious how you would answer that question.
Yeah, that's that's a really hot question now. And there was a recent, did you read the Olson Yaden? There was an interesting companion piece.
Yes.
Yeah. So, are the subjective effects important? And it's a very interesting, debate. And I guess my my take on it is that definitely I think it's a combination. I definitely think that there's a lot happening, from just the biological action, and it's possible that that there is, and that might underlie inflammation, for instance, like might underlie a lot of the disorders that like depression and anxiety. Even there's really a lot of really interesting research that is coming out to suggest that there's a lot happening, and this mind-body connection is really much stronger than I think we maybe had initially thought. But I do think that maybe there is an effect biologically, but the more from kind of like even like a narrative therapy perspective, or it's just the idea that we can construct meaning and narrative and use that as a kind of a touch point for one's sense of meaning, one's sense of self. I think that the people who are reporting not much happening, and and things and their outcomes are roughly equivalent to the ones who are having subjective experiences. I guess my thought is that there maybe is a way in which they might not be having a profound mystical type experience during the session, but my guess is that they the effects might not persist without some behavioral change or some integration that then kind of maybe harnesses some psychological experience. Really it's kind of like what's the pharmacological effect, what's the set and setting too, is another kind of interesting debate. or question here that we, that would be helpful for us to understand mechanistically. So I guess in short, without rambling for too much longer, I think that the subjective effect would probably increase the strength of, they may not be necessary, but it's, I do think that in a persistent way that there needs to be some like subjective way that people are sort of making sense of what happens. I think in a short-term way, maybe the biological effects could be enough. But
thank you, Gabby. I appreciate that. And I should also say, I'll let other people talk now. But I think I think Gabby, you and I probably met in like 2016 or 15 or before that.
Yeah, something like that. I think before that. Yeah, it's been a long time.
It's been a long time, but that means you were interested in this topic before it was cool. So, thank you for being a trailblazer and
thanks.
And being so passionate about this. The field is so much better off that you're in it.
Thank you.
Let me mute myself now and let somebody else say something.
Great. Thank you. Thanks for that really interesting question. It's a big one.
All right, so if anyone else has questions, feel free to drop them in the chat. I had a couple while we wait. One of them is, I'm not sure I've heard many people talking about how this would actually look in a real world healthcare setting. Like how does this actually interface with palliative care as it is? Like if you could comment on that, and maybe what sorts of new roles might emerge in that context.
Yeah, so in the earlier days when when it's mostly LSD, but again some other psychedelics, DPT and psilocybin were used in there were studies taking place at Spring Grove, Maryland. The Maryland Psychiatric Institute used LSD quite a lot with people like on their deathbed. So this can be, we were looking at people who were, who were at various stages, but this could even be used in like a hospice setting. There's really the safety profile is, at this stage also, if you're dying, it almost is kind of, it's less important, but not less important, but it is, it's a really kind of versatile medicine. So I do imagine that these could be used, maybe even one day with family, kind of maybe not in a group as with the family, but so much of the palliative care, and I've had some conversations with some palliative care physicians, and so much of the there is a lot of suffering that takes place within the individual who's the patient, but a lot of the suffering takes place in the family system. So how this would be integrated, like my hope is that it would potentially not just be used with with the patient, but thinking about interventions that include families, and there's palliative care is really all about like easing suffering and reducing the intensity of one's suffering. So psilocybin is really good at, or it can be very helpful, not for everyone, but for people who are really struggling to like make sense of their life, want to do a kind of like life review and to come to peace. I think it could be used pretty widely and in many different types of settings. So maybe in a post-prohibition era, we'll see something like that.
Thanks. I think so. I'll wait to see if anybody else. I could just keep going. So I think just continuing with this. I'm reminded of, you reminded me of, there's a character in Michael Pollan's book who I think was maybe part of the NYU study or something, who had some kind of terminal illness, maybe it was cancer, and I can't remember his name, but it's been a few years since I checked out the book. But he describes how like after his session, he sort of almost became like this yogi, and just like everybody around him would sort of just gravitate towards like, so you're talking about working with the family, and like the suffering person is sort of at the center of the family, and there's all this burden that's sort of extending outward on like their grief and stuff, and there's a lot to just be dealing with. And so I like that idea of integrating the family, and I feel like working with the person who's sort of at the center of this will likely have a ripple effect outwards. Like if they over, and I wonder if there's any research that's been done on this, if you actually help the person overcome their existential distress, does it then lighten the perceived burden on their caregivers? The nurses who are taking care of this person, family members, like all that. I
think it's such a beautiful question. I think my sense is that it would, that like it's not just an intervention for the the person, that it actually radiates, like it has this ripple effect outward. And it's such a beautiful kind of vision for the future, I think. And absolutely, I do think that that's true. And I know the person that you're talking about, he was someone that passed, he passed away a long time ago. I don't remember if his name was used as a pseudonym or not in the book, but he was he had a colon cancer, and his wife still talks about I think his wife is still around, and just talks about this. He's just was radiating this Buddha energy, and was really distressed though, when he came into the study. But it's profound, and it's like having being around the Dalai Lama, right? It just has this real ripple effect. So and there was a survey study. It looks like palliative care providers are kind of welcoming the integration of this, and there are some compassionate care in Canada. They are using psilocybin in a compassionate kind of care context. So there's ways of getting approval, for use, or kind of emergency use for this purpose. And then there's kind of also think about the assisted, I don't know what they're calling it these days, but the facilitated suicide. A lot of states now have this option, and that can be a really beautiful family experience where you get to, it's kind of I would say it's similar in some ways to this work, but but it has some differences, but it can be a very very powerful experience to be able to have people kind of die with dignity. And so I do think that in that way they're kind of similar, but the way we think about death is I hope we're maturing in that area. So
agreed.
I hope so.
So I think I'll take one more, and if we don't get any questions coming in, then I'll just
a little
let you
shy
go.
today, but we can end a little early, I guess.
So you touched on some of the stuff around post-traumatic growth. And this is something I'm really curious about, and I wonder if it's a property of psychedelic experiences that trauma narratives sort of just come up spontaneously for resolution. And this is something I kind of wanted to pick your brain about, if you think it's some property of psilocybin and other classic psychedelics, or if it's, or how much of this might be due to therapists in preparation sessions sort of addressing these sort of historical traumas with people, or not historical traumas, but traumas that they've had in their lifetime. Or to what extent they just come up spontaneously during sessions, and people are like, I didn't even remember that. I had no idea that was affecting me in this way. Can you talk a little about that?
Yeah, I'm pretty partial to I do think that these are coming up. I mean, there's a lot that, okay, so it's both, I guess. The preparation does. There's so much here, life narrative review, discussions of what is, how they've coped in the past, with difficult life experiences. And so there is kind of priming. There is a lot of expectancy and suggestibility that goes into this, into this treatment intervention. But, but going back to this slide of I'm sorry, I don't know why this thing is blocking this top image, but yeah, again, different than SSRIs, there's actually, I didn't mention this earlier about amygdala activity. So there's an interesting finding. There's some kind of conflicting, but like when you integrate them together, there's actually, it paints this interesting picture of of psilocybin correlating with this ego dissolution state of amygdala activity acutely is heightened during a psilocybin experience, but in the post-acute phase, it's kind of, it's reduced. So there are these experimental paradigms where they do facial recognition, there's like tasks that they do in the scanner. And so, acutely, there seems to be, which probably is correlating with, not just with the ego dissolution, but also this like emotional material, the limbic sort of system getting kind of released and flowing kind of in this upward motion into the sort of conscious brain, and the sort of top-down constraints are relaxed. And so SSRIs instead like dampen amygdala activity, but what we're seeing is like, there's this transient increase. So with trauma, it's possible that, trauma memories are surfacing, or painful memories are surfacing that had been repressed for a long time in this, kind of because of the psilocybin's sort of unique pharmacological action. But then they're finding resolution with the traumas, because somehow like there is something that gets kind of integrated into one's sort of interpretation of the traumas. So instead of just, it's like they're kind of like revisiting, it's kind of like an exposure, sort of like an exposure therapy, where they're revisiting the trauma memories, but something about this also, like this experience of like, if you get into the mystical, if you do have a mystical type experience of connection, Peter's proposed awe as a possible mechanism, these self-transcendent emotions, if kind of coupled with the, with one's experience of painful memories, it might actually help them like sort of emotionally process the experience. And so I do think there is something that, there is one study that's going to be starting at Ohio University, or Ohio State University, that is going to be administering psilocybin to veterans with PTSD, and that will be the first study. But I do really think it could be, it's just some interesting, with the qualitative data kind of pointing the way, or suggesting that that trauma memories, that this kind of gets activated and and gets processed somehow through sort of this like new learning that takes place, and integrating of like the trauma memories with more positive kind of affect. So yeah, I kind of took that question. I was excited about the question. So took it a little further maybe than you had asked or intending.
That's
but
great.
I do think it's a combination of, spontaneous, because and some people report spontaneous actual like rememberings of traumas that they had either forgotten or completely repressed, that they had never been consciously aware. So that's a kind of controversial, complex phenomenon.
I mean, for me, sorry, I was just going to say, for me, either way, to me, it seems pretty important then that guides are pretty well trained on how to deal with that when it comes up, and how to make sense of it.
I totally think that's like, we're training hundreds, thousands. I mean, so much, there's all these training programs coming online, which is important. We really need to train, clinicians, and a lot of these people enrolling, at least some of them are, anesthesiologists, or they work with ketamine in their practice, and I think it's great to get the training, but a lot of these people don't have trauma informed backgrounds. And I really think, even if you're not doing or even if you're not So I kind of, I hope that some of the takeaways from this, from my presentation is that like we haven't studied psilocybin for trauma as a primary indication yet, but so much of the qualitative data and the neuroimaging is just suggesting that that trauma, which is basically kind of a proxy for like repressed emotions that have been avoided, right? Like this is kind of an intervention that is it punishes avoidance and encourages approaching difficult emotions. So, and that's really what trauma or even depression and anxiety, there's kind of, it's a spectrum of kind of, sort of avoiding emotions that feel too difficult to experience. And so I think practitioners should have at least a basic foundational knowledge of how to work with trauma, because trauma is coming up in like all these, most studies, I think there's a trauma component. So not everyone, but not all the participants, but a lot, it's not uncommon. So I feel strongly about that piece. So
I share that feeling.
yeah, right. Yeah. So thank you, Dan, for your thoughtful questions. And I wonder if this would be a good place to wrap up. And I appreciate everyone coming today. And thank you, Peter, for chiming in, and Itamar for your support organizing this. And I will be reachable if folks want to, yeah, there's my last slide. If anyone wants to shoot me an email, I love staying in touch. So
thank you, Gabby, so much. We're so grateful. Really, it was really great.
I see Lindsay in their audience. Hi, Lindsay.
Hey, Gabby.
Lindsay is Lindsay, I guess kind of still is part of the NYU.